So now let's go into another set of extra beats, if you will. And it's really an escape beat, it's not an extra beat. We're going to look at ventricular escape beats. Just like in junctional escape beats, and junctional escape beats occur because the SA node failed to fire or the SA node was blocked. So the impulse never made it to the AV node. So AV node was waiting on it, never received it. It's waiting, come on, I should be receiving a signal or impulse now. Well, it's not happening, so I'll send my own signal. That's junctional. So that impulse is originated from the AV junction. So, and it's escape beat, so we're trying to escape death. So with ventricular escape beats, the same concept. So SA node isn't firing or it was blocked. Or maybe it's blocked to the AV node. The AV node did not fire. It did not send it was not stimulated to send a signal, and it did not start a signal, so it's not a junctional. So our backup to the backup is ventricular escape beats. So these occur after a pause in which the supraventricular pacemaker failed to fire. Now, whether or not it's SA node, traditionally the SA node would be it, but then we're relying on a backup to AV node. If AV node did not fire, then we're relying on our ventricular escapes, often coming from the Purkinje system. Same thing, if the ventricular conduction system doesn't recognize it, hasn't received a signal, so the Purkinje system is waiting on a signal that's never occurred, then it's going to send that impulse. Now keep in mind, if you remember, the intrinsic firing rate of the SA node is 60 to 100, AV node is 40 to 60, and the Purkinje system ventricular rate is 20 to 40. So if our SA node and AV node rate drops below what the intrinsic firing rate would be of the Purkinje system, then it may become the primary pacer. But again, it's still waiting on an impulse from above. It did not happen, so then the Purkinje system decides to initiate the impulse. So it could be just a single standalone beat, and then the heart kind of repolarizes, does its thing, and everything resumes, or it may continue to be its own rhythm. So with escape beats, again, especially ventricular escape beats, so pause in which the supraventricular pacemaker failed to fire, we have a QRS measures greater than 0.12 seconds. So you'll have a wide complex, absent P waves. If you do have P waves, they're going to come after the QRS complex. And it protects the heart from more extreme slowing or even asystole. So helps protect against death. This is our next firewall, if you will, before we get to that step. How are we recognizing it? So overall, still you're looking at with every rhythm. Look at the rhythm. Is it regular? Do you have P waves? What is the rate? Do you have QRS complexes, etc.? So in overall, this rhythm is irregular. So what makes it irregular? So we can say this right here makes it irregular. This looks pretty regular from here back. So we have regular rhythm here. This actually looks to be a first degree block. We haven't got there yet, but it's signs for first degree block here. So regular rhythm. We have an extended pause because this complex should have occurred somewhere right in there. Did not happen. Waiting, and finally the Purkinje system initiated the impulse, and so there's your escape beat. Escape beats look very similar to PVCs because they're originating from the ventricles, and the only difference between an escape beat and a PVC is where is it occurring at in the cardiac cycle. So now that you know what a ventricular escape rhythm, a ventricular escape beat is, let's explore ventricular escape rhythms. So a ventricular escape rhythm itself, also known more commonly as IVR. So ventricular escape rhythm, ventricular intrinsic firing rate is 20 to 40. So what might you guess what the IVR, or idioventricular rhythm rate would be? Should be around 20 to 40, maybe even less than that. So how do you recognize it? IVR is 3 or more ventricular escape beats occurring in a row at a rate of 20 to 40. If your IVR rate is less than 20, it's considered an agonal rhythm. So here's an example of IVR, or ventricular escape rhythm. So wide complex, no P waves. We actually have a P wave on the back side here after the ventricular depolarization has occurred. Have a P wave is occurring after it. Wide complex, rhythm overall is regular. That's another thing, most ventricular rhythms are regular. So IVR, AIVR, VTAC are regular rhythms, or appear to be regular. So overall regular rhythm, no P waves, wide QRS, so that meets the definition of idioventricular rhythm or ventricular escape rhythms. So what causes IVR? Well, it could be a failed conduction system that's occurred from the SA node, maybe a blocked impulse from our at the AV node. So somewhere in the atria it's not firing, it's not making it to the ventricles. So IVR may occur when SA node and AV junction failed to initiate an electrical impulse. The rate of discharge of SA node or AV junction is slower than that intrinsic firing rate of the ventricles, or it's generated by supraventricular pacemaker sites blocked, such as a third-degree block or something along that line. So you still have the impulse making it to the atria, is still being depolarized, but we are not getting that impulse to the ventricles. So the ventricles see that as, I've not received an impulse, so it sends off its own pacing mechanism. So that may yield a IVR. So may occur because of acute MI, dish toxicity, or metabolic imbalances. So what do you want to do about it? Really depends on, again, how stable is the patient. Remember, we're not going to treat just rate. We have to look at the overall picture of the patient. Is our patient stable? How's their blood pressure, the mental status, oxygenation status? If we have a problem with any of those, then yeah, we're going to need to treat. So if we have a slow rate and we have a loss of atrial kick, and we're going to have that loss of atrial kick because it's occurring after our ventricles have depolarized, then it's usually going to yield a decrease in cardiac output. If the patient has a pulse and is symptomatic because of slow rate, then we're going to have to go to transcutaneous pacing. That is a separate skill that you have, is transcutaneous pacing skill, and there's videos on it. Be live days for you to practice that. So if we have IVR, what do we need to do? We need to transcutaneous pace. You may be asking about, well, what about atropine? Well, atropine blocks the parasympathetic stimulation. So atropine's not going to increase. Atropine's only going to work for the atria. It's not going to do anything for the ventricular rate. So our next ventricular rhythm we're going to look at is accelerated IVR, accelerated idioventricular rhythm. So with accelerated idioventricular rhythm, it's IVR, only faster. So IVR rate was 20 to 40. So accelerated IVR is greater than 40. So accelerated IVR exists when you have a rate of 41 to 60, or 41 to 100. 41 to 100. So you have wide complexes, no P waves that precedes the complexes, rhythms regular, So, and your rate is between 41 and 100, makes that rhythm accelerated IVR. Rhythm is essentially regular. You have no P waves that precede the complex. You may have a P wave on the backside of the T wave, or it may follow the QRS complex, but you're going to be missing a preceding P wave. And if you do have P waves, they're going to be inverted, so keep that in mind, but you're not going to have P waves inverted or not that precedes the QRS complex. No P wave, therefore no PR interval. QRS is greater than 0.12 seconds. T waves frequently in opposite direction of the QRS complex. We can see that. So there's a QRS complex, or T waves up here. So again, it goes back to the same thing as PVC or IVR. Those ventricular initiated rhythms are oftentimes the QRS complex is going to be opposite direction of the T wave. So what causes it? It's usually considered a benign escape rhythm. May appear when a sinus conduction is slower than what the ventricular rate wants to be. So appears when the sinus rate slows and disappears when the sinus rate speeds up. So this is all could be a complete protective mechanism, and usually it is. So it's almost like a intermediate pacing of the heart. So it's the heart pacing itself. So SA node is not firing, the AV node isn't firing. So once that rate is slow, the ventricular sots in the Purkinje system recognizes we're not receiving a beat, so we're going to initiate an impulse, and that may become its primary pacer. So now if the SA node kicks in and starts delivering an impulse, then may see that accelerated IVR go down, and the sinus rhythm may just resume normally. So another thing, AIVR is often seen during the first 12 hours of an MI, and it's common after successful reperfusion therapy. Different causes: dish toxicity, cocaine toxicity, subarachnoid hemorrhage, acute MI, hypertensive heart disease, dilated cardiomyopathy. So any of these are possibilities. Now, if we know there's something and we can link whatever the cause is to the rhythm, and we can try to treat the underlying cause, obviously. Do not try to treat AIVR in itself. If you knock that rhythm out, you've just killed your patient. So if our AIVR rate or IVR rate, regardless of what the rate is, for these two rhythms, if we try to knock that stimulation out, just because it's wide and bizarre, complex, does not mean we need to treat it. So if you try to slow that rhythm down, it should be slowed down anyway. So if you knock out their only mechanism they have of living, you've just killed your patient. So as I just mentioned, treatment's usually unnecessary. If the patient's symptomatic because of the loss of atrial kick, then atropine may be ordered if we think, but it's only for the atrial kick. It's not doing anything for the rate. Now, if we have a separated atrial and ventricular rhythm, and in case of a third-degree block, not trying to confuse you what AIVR versus third degree is, but, and we'll talk about that more in the next couple of weeks, but basically the conduction is lost between the atria and the ventricles, and they're both are independent now. So you have your atria firing, your ventricles firing, but they just don't communicate with one another. Atrial pacing may be attempted, but that's not through us. Now, if our AIVR rate, and again, very seldom would we need to treat that, because our AHA protocol, if your rate's less than 50 on bradycardia, you don't treat it. I mean, we may treat by other means, but we're not going to pace it or not going to administer atropine. But if we have AIVR, again, that rate goes from 41 to 100. If it's in that 41 to 50 range, you can consider transcutaneous pacing. If it's greater than 50, we're going to have to support in other means, such as improving perfusion, improving blood pressure, improving cardiac output by medication, not by electrical.